My name is Steve Jepson, and I am the Senior Vice President of Commercial Markets here at CareFirst. I'm pleased to welcome you to today's discussion, The Disrupted Middle, Bridging the Coverage Gap for Small Employers and Consumers. We all know affordability remains one of the most persistent challenges in our healthcare system. While much attention has been paid to coverage expansion for low-income individuals through Medicaid or premium subsidies, there's a growing group that too often gets overlooked: small businesses and middle-income consumers who don't qualify for help, but still struggle to afford comprehensive health insurance. These are the folks we are calling the disrupted middle. We're seeing them being squeezed by rising costs, left behind by policy gaps, and increasingly turning to alternative arrangements to keep coverage within reach. At CareFirst, we remain steadfast in our support of the individual ACA, small group ACA, large group fully insured programs, Medicaid, Medicare, and the dual eligible market segments. We are also committed to finding innovative solutions to support the people and businesses in this disruptive middle, and we firmly believe there's room for policy and market innovation to better serve this population. It is also why we are thrilled to bring together a panel of experts with deep experience across academia, the broker community, and the legal and policy landscape to explore this important issue. I hope today's discussion sparks ideas, questions, and partnerships that move us towards a more affordable and equitable system for all. Now I'm delighted to turn it over to our moderator, CareFirst's own Burcu Bozkurt, Director of our small group commercial markets. Burcu.
Thank you, Steve. I'm excited to be leading this discussion today. As Steve just mentioned, today's conversation centers on a segment that's too often left out of policy debates and marketplace innovation, small employers, and unsubsidized consumers. And it's safe to say that traditional boundaries between employer coverage and the individual market are shifting, whether due to affordability challenges, workforce changes, evolving consumer expectations. The small group market has shrunk considerably over the past decade, and more people are navigating coverage options on their own, often without financial help and without the resources larger companies can provide. And we know this is happening rapidly. In 2002, approximately 47% of small employers offered health insurance as a fringe benefit, compared to 30% in 2023. So this disruption has given rise to new models, including ICHRA and level-funded products that are trying to fill the gap. But questions remain. Are these models working as intended? Are they sustainable? What are regulatory and equity implications, and what's next? So in order to get real answers, we must confront this challenge head on with clear data, honest dialogue, and insights from those closest to the issues. We didn't convene this panel just to restate what's broken. We're here to push the conversation toward what real solutions might look like and what questions we should be asking next. So let's get started. Today, we're going to hear from Michael Rachesky, the Regional Vice President for Mid-Atlantic Sales at Corporate Synergies, Lisa Campbell, a principal at Groom Law Group and co-chair of the firm's Health Services Group, and Dr. David Anderson, an assistant professor in the Department of Health Services Policy and Management at the University of South Carolina, Arnold School of Public Health. And I'll let them introduce themselves. Mike, let's start with you.
Yeah, good morning, Burcu. Thank you. Thank you for having me. My name is Michael Rachesky. I'm the Regional Vice President of Corporate Synergies. I've been in the industry for more than 10 years. Half of that time has been as an executive at the largest national carrier in the country. And while I was over there, I frequently worked with state regulators, collaborated with product teams to build solutions, worked with underwriting and actuarial teams to price insurance here locally in the Mid-Atlantic. And I'm now on the consultant side, helping clients navigate all solutions available to them.
Thanks. Thank you, Mike. Lisa?
Great. First of all, just want to say thank you to CareFirst for hosting this discussion. I'm excited to be a part of this panel. My name, as Burcu said, is Lisa Campbell. I am a principal at Groom Law Group in Washington, D.C. I'm also co-chair of the Health Services Group at Groom, and I support carrier clients on all aspects of healthcare compliance related to the Affordable Care Act, No Surprises Act, mental health parity, et cetera. Prior to joining Groom, I worked at the Department of Health and Human Services Center for Consumer Information and Insurance Oversight on ACA implementation. Prior to that, I worked at the Maryland General Assembly and the Department of Legislative Services on healthcare issues. And then prior to that, I worked at the Department of Labor on pre-ACA healthcare issues. And I, again, am excited to be here and look forward to the conversation.
Thank you, Lisa. And Dr. Anderson.
Thank you very much, Burcu. I'm Dave Anderson, a PhD, assistant professor at the University of South Carolina, Health Services Policy and Management. Previously, my research agenda for the past decade has been on how do people use the Affordable Care Act, how do insurers respond to policy shocks, and how do people make predictable choice errors, and then how do we respond to those things? Because choosing insurance is really difficult, and trying to figure out how people do that, I think is really important. Before I went into academia at Duke University, I was previously working at UPMC Health Plan in Pittsburgh, building their provider networks as well as managing their risk adjustment for their Medicaid product. I had received a master's in public policy from Carnegie Mellon, and I bring this pragmatic, evaluatory, and industry-focused lens to all my research questions because health insurance is important. It improves people's lives, it improves people's mortality, but it's really complex. So trying to figure out how to make it better and easier is really important to me.
Thank you. Thanks, Dr. Anderson. I'm excited. So to begin, let's just define the population at the heart of today's conversation. So we often hear about two ends of the coverage spectrum, right? The uninsured and those without comprehensive subsidized coverage. And some of that makes sense, right? Approximately 92% of Americans enrolled in the Affordable Care Act marketplace plans for 2025 received a federal subsidy. But we know not enough attention is paid to this disrupted middle. So Lisa, what does this group look like today? And what do you think why do you think they've remained underserved and overlooked in policy conversations?
Yeah, I think, when I think of the disrupted middle, I think of those small employers, so 2 to 50, definitely under 100, who are, building a business, right? They're, smaller, so they don't have, a lot of the extra cash flow necessarily. And so, they want to offer health insurance, but I will say, and it was mentioned earlier, affordability is really, I think, the biggest barrier, for those small employers to be able to offer, health coverage. Part of this group, I think you could think of, the self-employed individuals who, have maybe just themselves and one other person or a couple other people, they fit in there as well. And so I think self-employed individuals are also part of this, how do I, afford health insurance, for me and the few people that work for me. We also have gig workers, I think more and more in our country, these individuals who kind of are acting as independent contractors, out there kind of, probably doing, fairly well from an income standpoint, but still, I think making, too much to be able to qualify, for subsidies. And that's where, I do think when you think about we have our small employers, but then we have, the individuals who are really, kind of at that level where they make too much, to be able to qualify for that support, but at the same time, still not enough to be able to, afford the health coverage that's available. I do think, there have been efforts to try and, increase enrollment in the small group market, kind of boost the small group market. But it has been a real challenge. And again, I think it's, it comes back to, that affordability, kind of question or issue. So I do think it's a harder, group to be able to solve for. And, we'll be able to talk about, kind of later on, some of the ways that maybe this group will be able to, think about health coverage differently, for their employees. But I definitely think when it comes to, being able to put food on the table or a roof over your head and health insurance, those day-to-day costs, are going to win out. And I think that's a problem. I think, trying to find ways to get, this middle group, the, disrupted middle coverage is really important.
One thing I'd like to extend upon Ms.
Go
Campbell's
ahead,
comments
Dr. Anderson.
is that the individual market has a data visibility challenge. We have very good visibility on exchange enrollees at the aggregate level. The state-based marketplaces are excellent about sharing the data. CMS, however, does not share all too much data with researchers or with other interested parties, such as all of us on this call, that's de-identified, stable, and trackable over time for the off-exchange population. So it's hard to make strong statements about this group because we don't observe them well. Like there is some data available with state all-paid claims databases. There's some data available through Mark Farrer and Associates, but we just don't see this population. And the ACA as a whole for the individual market is the remainder of the remainder. It's the leftover market. So this small segment of the excluded middle is leftovers of the leftovers. And we don't observe them well. So we need CMS to help us see these folks better.
That makes a lot of sense, Dr. Anderson. Let's talk about the big kahuna that's on everyone's minds right now and grabbing the headlines, the Enhanced Advanced Premium Tax Credits, or EAPTCs. So the original ACA premium tax credits were made more generous or enhanced in the American Rescue Plan Act in 2019, and then extended in the Inflation Reduction Act in 2021. We know they've played a critical role in improving affordability for millions of Americans, but they're set to expire at the end of this year unless Congress acts. If they aren't extended, many people who currently qualify for help will face steep premium hikes that just diminishes or disappears altogether. Lower income individuals will certainly feel the squeeze, but so will many middle income consumers in high cost regions like here in the DMV, where unsubsidized premiums can easily top $800. For some local context, 7 out of 10 people with APTC in DC are sole proprietors and small business owners who buy their own health insurance. These individuals may not qualify as low income, but they could still be priced out. So what will happen if the EAPTCs lapse? The disrupted middle will grow. Based on what you know about the market, Dr. Anderson, what will the fallout look like if the subsidies aren't extended?
We should expect substantial disruption. The Congressional Budget Office is projecting millions of fewer people receive it being covered next year under current law, so without the enhanced APTCs. Because folks who are earning over 400% of the federal poverty level, which for a single individual is about $63,000 to $64,000 a year in the continental US, will have a massive price shock, going from 8.5% of their income for the benchmark plan, which is roughly $5,000 or $450 a month, to $1,000, $1,500 a month for their coverage. We should expect individuals who are relatively healthy, who make over 400 FPL, to leave the market. They might find coverage through association health plans, they might find coverage through short-term limited duration plans, or they might go uninsured. So we're going to have a much more morbid, sick market, which means premiums are going up. The preliminary rate increases, which are being finalized right now, are substantial, between 20 and 30% nationally. A substantial component of that is the risk pool is projected to be far worse next year than it is this year. And this is going to really matter for both the individual market and for some small groups that are trying to cover their employees through an ICHRA arrangement, individual contribution health reimbursement account. I think they've been renamed as choice accounts due to the One Big Beautiful Bill.
That's right.
where we can basically think about ICRAs or choice accounts as if they're a 401k for health insurance, but the money has to be spent on ACA regulated plans. So that dollar stretches far less next year than it would this year. So we're going to see a massive amount of price pressure. And for the folks who remained insured, we can also probably anticipate a substantial downshift in the quality of their coverage from gold to silver, from silver to bronze, as they look for lower premiums, but far more exposure if they do need to use medical services.
Yeah, and one thing to add, I mean, I think I agree, with what Dr. Anderson was saying. I mean, I think, the provider groups are bracing, for this. I think when you kind of lose, that health coverage, you lose access to those preventive care benefits. People with chronic conditions, will possibly end up in, emergency rooms more often than kind of would have been otherwise with coverage. So I really do think it's not just kind of an individual, employer problem, but, we're seeing providers who are very concerned, about the impact of this as well, just from, their ability to deliver care and to deliver it in a way that makes sense, for consumers. So just wanted to add that.
Thank you,
Yeah,
Lisa.
both very comprehensive answers, and I agree 100%. The only thing I'd like to add and reiterate is what Dr. Anderson said, is that essentially you're going to see a domino effect, leading to a higher uninsured population, which generally means higher emergency room utilization when people are going to get their care. So what that means is the emergency rooms are going to start taking on all this bad debt that they're going to write off, which in turn gets renegotiated into the reimbursements that the carriers are paying. So, it all leads to the same thing that the other two panelists were talking about: increased price for the end consumer.
I need to push back a little bit on what Michael was saying about the ER. The evidence has shown that insured individuals or people who newly gain insurance use the ER substantially more than uninsured individuals. I agree with you that there'll be substantially more bad debt throughout the entire system as the entire payer mix is changing between the combination of changes to the ACA and changes to the Medicaid program. But I don't believe the ER is going to be where we're going to see the worst damage.
So we're talking about substantial impacts here, both to the healthcare system, increased churn in the market, with this help diminishing or disappearing altogether in the form of the EAPTC subsidies. We also know that many small employers, as is, want to offer coverage, so without these disruptions, but find the traditional small group market is limiting or doesn't work for them for a number of reasons, which include affordability, but also extend beyond. So, Mike, how are you seeing this play out on the ground right now? And what alternative options are gaining traction?
Yeah, so with federal subsidies scheduled to end for the ACA marketplace, we're planning for more people to look to join their employer's plan. Unfortunately, if the employer tax credits are also not extended by Congress, it's likely you'll see a fall off of employer contributions to their employees' health care, which would lead to a higher uninsured population. I do potentially see, and I think I've seen a couple of articles out there where some states are looking to fill that gap by funding subsidies of their own. Now, how they're going to do that is a different conversation. And the Mid-Atlantic encompasses really three different areas, right? You've got Maryland, DC, and Virginia, and each state has different rules for small employers. But we're looking at a range of solutions, most notably individual coverage health reimbursement arrangements, also known as ICRAs, and level funded plans. So just real quick, for those who don't know, ICRAs allow for employees to shop for their own health insurance, which is then reimbursed by their employers. And level funded plans are a type of alternative funded plan, allowing for medical underwriting, among other advantages, that will allow for rates to be adjusted to that employer's specific employee population versus the overall health of the region, which leads to lower overall premiums for employers in most instances.
Building on what Mike is saying, underwriting in the level funded market is very good for most employers. We do need secondary solutions for those employer groups that cannot underwrite well, that have an older, much more morbid population. And some states have considered merging their small group market because it has been so adversely selected, because any healthy group has left already to their individual market, which is much larger and much more stable. So that is one possibility, maybe not for this year because we're too late in the cycle, but for 2027, 2028, 2029, as a fully insured, ACA regulated small group market is just being adversely selected because there's viable outside alternatives for healthy groups. Merging into the individual market might be a source of stability.
Yeah, interesting. And I just want to pick up on, what Michael was talking about related to, ICRAs. I definitely think, at least, from what I'm experiencing and working, with, plan sponsors who are, offering this coverage to their employees, ICRA is becoming, more and more part of the conversation and part of the, the options that they're thinking through. I do think, what it offers to employers, is that, I can give my employees a fixed amount and they can go buy coverage on the individual market. They can pick the plan that works for them. It's, I don't have to worry about plan options or figuring out, what's going to work for the majority of my employees. They have the ability to really go, into that market and pick the plan that works for them. So I think that's kind of great flexibility. I also think for small employers not having to worry about compliance costs, the issuer is really the entity, here who's responsible for compliance. So those are some really positives, for small employers. I do think one big key, and I'm sure, Dr. Anderson would agree with me, the big key here is we need a functional individual market. And, without a functional individual market, the ICRAs, I think, would not work. And that's really the interesting thing. We have an administration who is very supportive, of ICRAs, like you said, in the one big beautiful bill, kind of codified a lot of those requirements, calling them choice accounts. But at the same time, not necessarily, fully supporting the individual market. And it's an interesting, kind of question, kind of the connection between the two. And so I really do, think we need a good, strong individual market for those ICRA accounts to work. Up until this point, I think, individual market has been, very stable, I think considering it's come a long way since 2010. And, we had seen the most growth we had, seen, these past few years. This year, I think we're all kind of, sitting a bit on the edge here, not sure what to expect. With those rate increases, will carriers pull out, of the markets because of, now, all of this instability and, the enhanced subsidies potentially not being there. So I do think it's, the future is not as clear as maybe it was, 9 months ago, but I do think ICRAs seem like a good alternative for employers. They do have guardrails, at least under the current regs. So I think that's, that's important. It does limit flexibility, for the offering of ICRA. Even with those guardrails, though, I think we are starting to see that growth of the ICRAs, so whether they'll continue, whether the Trump administration will take this on as one of their policy initiatives to try and find ways to maybe loosen the guardrails a little bit, I think remains to be seen. But I do think ICRAs are something that we should all be keeping kind of our eyes on as, a potential, growth area for small employers. Again, depending on, what happens with the individual market. And then level funded plans, I think these have been around, for a while. I do think, the underwriting, is the cautionary tale there. They're not subject to, the essential health benefits or, the community rating. But, they do have some advantages for employers. Again, the employer is going to pay that, that fixed cost monthly, the claims account, the admin fee, and then the stop loss. So there is some protection, from, I think those high risk claims. And, the positives are, I think the employer will, be able to kind of have some flexibility, implement some wellness programs, have access to data like you were talking about, Dr. Anderson, being able to look at kind of what's happening with their employee population, put in place certain programs that maybe can help, reduce costs, because I think there can be savings, for small groups who have a relatively healthy population. If they don't spend all of it on claims costs, there could be refunds back to that employer. But, I do think those are two interesting solutions, that small groups are definitely looking to. I think, for the individuals, we have this new catastrophic plan, that's available now through a hardship exemption, not now, but it will be beginning November 1st, through a hardship exemption. So some individuals who are really just looking for something, to protect me in the event of a catastrophic health event. It's high deductible. You get, your 3 preventive care visits or your doctor visits. But at the same time, I think that seems like, that would be something that could help individuals, in kind of this group better than short-term limited duration, because it is comprehensive. ACA coverage, will have, a lot of the requirements. But I do think it is, whether or not that ends up being a solution for individuals who aren't eligible for subsidies, at any age, I think remains to be seen, since it is kind of this new opportunity that will become available.
Yeah,
Thanks.
so,
Oh, go ahead, Mike.
yeah, sorry, Burcu. Being on the carrier side in executive capacity for a few years, I just want to acknowledge that, yes, the cherry picking does exist, the adverse selection against the community rated risk pool. It does exist initially, but I think it's important to add the context that after year 1, small employers are not credible, right? Meaning that the law of large numbers doesn't necessarily apply to a small group directly. As a broader risk pool, yes, it does, but on an individual basis, it does not. So that underwriting that is advantageous in year 1 can flip on you pretty quickly if you're not managing, or if your employees aren't managing their health appropriately. And that happens in the ACA pool as well, right? The adverse selection exists, the risk gets worse in the ACA pool in theory, but also in theory, that population health can shift to the positive, and you can see lower medical trends. The other thing I wanted to add in is ICHRAs are becoming a very, very attractive solution, which I think is by design, and especially for high income earning individuals. I'd be looking at an ICHRA for them to particularly leverage bronze plans in particular, which in 2026 are going to include the ability to have a copay before the deductible and also a health savings account. So yes, you have wealthy individuals who I would be recommending to go in with an ICHRA, select a bronze plan, and get a copay and the ability to save on a tax-deferred basis.
Michael, I appreciate you raising the fact that high deductible health plans are now going to be universal for bronze catastrophic, because that is a huge change. And for individuals with liquidity and assets and low health care utilization, it's going to be a massive benefit. One last thing I want to bring up about ICHRA at the moment is we have to remember that it's fundamentally a different product. Most individual marketplace plans are HMOs or EPOs. Most of them have narrower networks. Quite a few of the lower cost ones are built on Medicaid plus platforms rather than commercial minus platforms or commercial regular platforms. So the premiums tend to be lower, could be lower at the bottom end of the premium scale, but it's fundamentally a different product. And we just have to keep in mind that there's going to be some matching issues. Like some people previously would have really have liked the small group offering if it was available due to network, due to PPO status, and that might not be available to them. So like it's a good situation for most people most of the time, because most people most of the time don't use a whole lot of services. But we have to be very aware that's not a perfect, everyone's better off solution.
And to that point, Dr. Anderson, legislatively, I think there are some gaps to be filled for those employers who are moving over to the ICHRA platform, right? Specifically around qualifying events and what's the other one? Qualifying events and COBRA administration, right? Because on an ICHRA, there is no COBRA.
Not really, no. But fundamentally, the individual owns the policy. So if they lose their employment, they still own the policy, and they don't even have to pay the extra 2%. So they might be coming out ahead relative to COBRA under the old school. So yeah.
After they lose their employer subsidy, right?
Yeah, but they were still losing their employee subsidy under COBRA anyway.
Right.
So
right.
Yeah. And I think that's one of the benefits of ICHRA too, is like you can keep it, right? Like you don't, just because you lose employment, you don't lose access to maybe this plan that you've chosen that works for you, works for your family. It is portable in that way. Like, just because you lose employment, you would lose the subsidy, but I think as we were saying, you would lose that anyway. But I still think it's something that you could kind of take with you. It becomes, somewhat portable. So
yeah. And then following on what Lisa's saying, you lose your employment, you keep your ICHRA, you get a job, and ideally you can redo your paperwork and still have a new subsidy put in. So some of my research is looking at like the health effects of breaks in insurance coverage, not go from insured to uninsured, but go from A to B. Minimizing those breaks is probably a long run health improver. So ICHRA should do that.
Interesting. We're talking a lot about what makes ICHRA and in a way level funding kind of promising, in terms of new tools, new solutions for small groups. We did talk a little bit, and I kind of want to double click on this, additional guardrails that we would need to consider from a policy and regulatory perspective. Lisa, you touched on that a little bit. Mike, you touched on that. But the question I want to hear y'all's perspective on is, how do we make space for innovation without cannibalizing the ACA market or encouraging risk segmentation that undermines the broader risk pool? Is there anything else beyond, Mike, you suggested COBRA, additional clarity around qualifying life events for ICHRA. Are there, Dr. Anderson, I think you talked about combining risk pools, growing the risk pool. Are there additional policy and regulatory guardrails that need to be considered here?
I mean, I do think ICHRA's, sorry. Yeah, I guess the way I'm thinking about ICHRA's is, again, we need that strong individual market and, having kind of employers, buy into that. So, fund kind of employees to go and buy individual market coverage. I think that is actually a real win for the risk pool. I think, you're going to, have kind of a broader group coming in, and buying coverage. Now, obviously, you wouldn't want just kind of the sickest of the six, going in there. But I do think, employers are generally diverse in kind of the makeup of their groups. And, so I do think if you think of it in sheer numbers, and Dr. Anderson probably has more data on this, but if you think about it in numbers, having more people kind of go into the individual market should strengthen it. And employers, having that broader population. I would think, giving employees money to go, buy coverage on the individual market, would be something that would be an incentive, right? Here's money, go buy coverage. You can have health and coverage that way. I guess it depends on how much the employer is really subsidizing. But I also, could you have employees, because the way the ICHRAs are set up now, right? You're picking classes of employees that you're offering that ICHRA to. I think some of the concern is, would you be picking kind of those classes of employees, that would be your higher risk, potential populations, and then putting that, into the market. But I still think in sheer numbers, I feel like, that that should even out. But I don't know, Dr. Anderson probably has data to speak to kind of the risk point of would ICRAs really add kind of adverse, selection for the individual market with putting those employees in there.
One of the challenges we have with ICRAs is our data is just not good. The HRA Council has estimates of several 100,000 people, plus or minus several 100,000 people for people with ICRAs.
Large margin, right? Yeah.
Yeah, the margin is almost as large as the estimate. We don't know. I agree with you that large groups on average tend to be pretty healthy and pretty diverse. I think one of the things that could be exceptionally helpful to the ACA risk pool and the small group risk pool would be if large state or municipal governments or school districts move some of their populations into ICRAs. Because at that point we could potentially get a virtuous cycle of, oh, we have a pretty healthy population that really is demanding a different type of product. And that product demand could be met with broader networks or PPOs, and then we can have a discussion with societal CMS about how do we think about risk adjustment and what it prioritizes. Because if risk adjustment will never be perfect, what we choose to accept as an acceptable error shapes the market. So thinking about how that works makes these markets a whole lot more effective. I want to bring back a point that Burcu raised that I want to push on a little bit of like, do we fundamentally mind if most of the ACA individual market is effectively a de facto high cost risk pool that's very well subsidized, as long as other segments of the market work and as long as other sources of good coverage, let's not define what good means for the next 5 minutes, are available for 98, 99% of the population. No, so I think that's a philosophical question that I want to raise and then just leave floating out there. But like, the ACA is a part of the solution. It doesn't have to be the only solution.
You make a great
talking
point.
about,
Go ahead, Mike.
Oh, sorry. Yeah. If we're talking about combining risk pools, maybe we should take a look at reducing the amount of CMS rating areas in a state to increase the amount of covered individuals and also help blend risk pools within the state. So a good example is Northern Virginia, typically a young and healthier population due to the high presence of government and technology. If you were to look at the county or the rating area down from that, or even just a little bit further to the west, you start getting into the Appalachian areas, which are historically very unhealthy. So if you were to combine those two, yeah, the rates would come up a little bit for the Northern Virginia area, but the rates would go down significantly for that rural population. I think that'll probably have a bigger initial impact than combining the individual and the employer or in the ACA rating pools, right? Because I mean, you're taking a healthy population in Northern Virginia and combining it with a healthy population in Northern Virginia, and the outcome's still the same. Yeah, it provides broader stability to that particular market, but it does nothing to address the rural areas and the more suburban areas where there are real issues with the healthcare population.
I can see the elegance of that. There's definitely questions about urban to rural, urban to suburban transfers, because that's what that would do. Texas had done the opposite. Actually, Texas had done something similar where they had metropolitan rating areas, then one catch-all rural area that they then divided into like 18 different new areas. And the researchers found that, yeah, it's a transfer of funds out of the urban area into the rurals. And that's a politically fraught question, I would imagine.
It is. And, you know, at least in our area, right, in that example, Northern Virginia, the average income is much higher than that of the rural area. So I would think it would kind of, and maybe this is a more socialist view, but even out and allow for greater coverage or greater insured populations in that rural area.
There's that potential, yes. But I think the politics of it are pretty tough.
Yeah, agreed.
Fortunately, we do have some tools that currently we know work, such as reinsurance, highly effective at reducing premiums and stabilizing the individual market, which we've stated is kind of key to ICRA growth or ICRA stability. In Maryland, premiums have decreased by more than 20% since the launch of their state reinsurance program. However, even with premium tax credits and tools like reinsurance, risk adjustment, which we've talked about, affordability challenges are still persistent in the small group market and individual market. So Dr. Anderson, can you talk to us about some affordability levers that we haven't pulled yet or haven't pulled hard enough? And how do we ensure these policies don't widen disparities or undermine market stability?
Thank you very much for an excellent question. We have a good evidence that reinsurance does bring down gross premiums. We can design our reinsurance program, I think, a little bit better. Right now, reinsurance is based upon the net allowed claim before risk adjustment. Because a $100,000 claim a year for an individual under most reinsurance programs will get the same reinsurance payment, even if that event that generated a claim in one scenario has an $85,000 risk adjustment payment attached to it, and another scenario has no risk adjustment attached to it. If we optimize our reinsurance to reinsure net of risk adjustment, each reinsurance dollar goes a whole lot further and allows for a much more effective market. So that's one thing we can do. Maryland has the young adult subsidy, which we find is exceptionally effective and efficient at enrolling individuals under 200% of the federal poverty level. So this does not directly affect the disruptive middle. However, the folks who are coming in under the young adult subsidy program are extremely low utilizers, which means that they bring down premiums. Now, it's a positively selected pool. Anything that we can do to systemically make it easier for younger, healthier populations to enroll, such as combining a state-based marketplace like Maryland and a data merge with the state tax authorities to identify individuals who are likely eligible but not enrolled, and sending out letters and saying, hey, please sign up because you have a zero premium plan. That is positive selection that brings in healthy folks. The big question is how much state funds can a state allocate to these efforts? Reducing barriers to enrollment is probably the most efficient use of funds. Subsidies are probably fairly inefficient because most of that subsidy is going to folks who would have enrolled anyways. So let's try and make it easy for people. So that means navigators. That means making sure that brokers have good, easy platforms. That means pre-populating data with as much as we know from pre-existing data. Let's make it easy. And that, I think, helps out the entire marketplace.
Yeah, and just
Oh, go ahead, Lisa.
oh no, go ahead. I'll go after you.
I was going to say along those lines, I was going to say, we know that successfully serving that disrupted middle can be tough because as we've talked about in this conversation, they may have complex health needs, there's diversity, there's also limited purchasing power inherently. And so I kind of wanted to ask Mike, let's start with you. What kind of solutions, whether it be tech-driven ones, product-based, regulatory, could better equip brokers and advisors to support this group in the theme of let's make it easy?
Oh, Burcu, it sounds like you're giving me free range to go off topic here a little bit. So
not too much free range, Mike.
I got a whole list of answers here. So I think the obvious answer is for Congress. We need for Congress to extend the EAPTCs and the subsidies on the individual market. I think that'll have the biggest impact in the short term. In the longer term, Americans overall, including myself and a lot of people in my family, which I will use as examples in meetings all the time, have a generally reactive nature to healthcare, and I'd like to see more innovative solutions around engaging all consumers in preventative and proactive care. The next thing would be, which I think all these exist already, but to what level is another debate. I'd like to see more robust comparison tools for both employers and individuals, better transparency data, better data transparency, and maybe some regulations around aggregation of providers and facilities to control costs. And then lastly, maybe encourage carriers to look more at patient assistance programs at some of these large providers and hospital systems, to hold them accountable to their policies that they have for low-income individuals, meaning lower cost to the employee, lower cost to the patient, and then overall lower cost to the health plan, leading to lower renewals and lower rates.
Thank you, Mike and Lisa. I know I cut you off before.
No, yeah, no, happy to follow up on Michael's comments. Just a couple threads that I feel like have been kind of streaming throughout this conversation that I think are really important. One, I think a couple folks touched on just, helping individuals find the coverage that works right for them. I mean, that's an individual market issue, that's a small employer issue, that's an ICHRA issue, I think folks have access to coverage, but, really important to try and help them navigate, the complexity with all of the options available that, are on the marketplace, and, helping them find the plan that works well for them, whether it is kind of a high deductible, or if they have a family member that has a certain condition, making sure that what they're getting, will be kind of helpful for their needs. And, can't overstate that. When I was at CSIO, I was responsible for the Navigator program and the Certified Application Counselor program. And, just a lot of money was directed towards those organizations because I think folks felt like it worked to have that touch, have people that were there to kind of help individuals, whether there were language assistance barriers, or, just individuals who just, we understand health insurance because we live in it every day, but a lot of folks don't, like looking at, the website and trying to make sense of, in network, out of network, what drugs, what services will be available. So, I don't think that's a priority right now, just kind of for those programs. But I do think carriers, have really kind of tried to step in and provide, some of that information to help individuals, who are looking, for coverage and, that assistance to help pick a plan that works for them. So I think, not losing sight of, trying to find the tools, where they're available. And states obviously are doing kind of different things than the federal government. So I think that's important. Another thread that I feel like has been talked about, is the transparency. This is an administration, and I think the prior administration supported transparency, issues and trying to get, information out there. I think one of the problems that we have right now is all that information is out there, but nobody can really do anything with it. And so, I think because of all the resources that have been spent, on transparency, trying to figure out like, how do we use, some of this data to be able to, help, employers, help, entities who are trying to enroll in coverage and understand, more about, what are the costs of all of this and how does it all work? So I do think those cost share tools that I know carriers have spent a lot of time, putting together, trying to just generate some usage of those to really help people who have coverage to be able to use it effectively, and get out of it, what is being put into the system. So I do think that's important. And, I think we would all agree those enhanced subsidies are just so important. I can't tell you how many conversations I've been in over the past, several months, about the importance of them, going away and the impact that that will have, on kind of Americans. I think we can absolutely, expect our uninsured population to go up. And, just again, not as healthy Americans, that we had previously because of that lack of the ability to get that preventive care, go to the doctor when you're sick, be treated for those chronic conditions. So I do think, some of this is in the hands of Congress and the administration. Some of it I feel like we have we have some tools that we could really put to good use and try and just, get more folks kind of in the right coverage. And then ICRIS, I think my last point will be, I really do think that that's a good growth opportunity, whether or not there are changes, to ICRIS, from this administration to make them a bit more flexible. I think, some employers that I've talked to would welcome that. I think they want to be able to offer it more broadly, but the guardrails, are pretty strict. And so I think trying to think about ways that you can open that up a little bit, but also not, make sure that individuals are protected and there's not kind of this dumping of, adverse risk and things like that. So I will turn it back to you.
Thanks, Lisa. So we've talked a little bit about what policy or industry trends you are watching that could help reshape the landscape for small employers and middle-income individuals in the next 3 to 5 years. I heard ICRA. Let's build on that. Dr. Anderson, any that you're looking for or watching for in the market in the next 3 to 5 years?
The biggest challenge is price level. Like, our discussion is much easier if average U.S. prices were 120% of Medicare instead of 150% or 180 at 200% federal poverty level. Sorry, of Medicare price levels for the commercial markets. So anything that brings down prices, which means we need to think about, what does network adequacy mean? I have work in progress that shows that our current network adequacy regulations do not change insurer behaviors. It probably just increases premiums. So we need to think about that. We need to think about the Federal Trade Commission. What types of mergers are approved? Which ones are broken up? We need to think about how pricing dynamics happen. And I agree with what Lisa is saying, that ICRA is a tremendous opportunity because it breaks some of the principal agent problems, some of the pricing problems. Because right now, if I am the chief HR officer for a firm, I'm trying to get health insurance that is both fit in my budget constraint and minimize the number of people with power who yell at me.
Yep.
Which means I want a big, broad network, which is probably too much for most people, which means I pay through the nose for that privilege. ICRA breaks that problem. So those are the things I'm looking at. And then we need to figure out, how do we keep drugs unavailable, even though they're theoretically coming off patent, but they're still unavailable due to pay for delay, patent thickets. How do we actually make these markets work? Because our markets don't work well right now. So those are the things I would be looking at over the next couple of years.
Great. Mike, what about you?
So I'm interested in the comments that Dr. Anderson made around network adequacy. I'd love to take a look at that study, because I've kind of been looking at it. I've been looking at networks myself recently and wondering whether or not discounts really mean anything. If the total cost, the episode of the total cost of care is high because of readmissions and things like that. So I think Dr. Anderson and Lisa covered them both pretty well. I don't think I have much to add to that.
Sounds good. Lisa, anything else to add beyond ICRA's, what you just stated?
Yeah, I mean, the only kind of other type of coverage that I know is something this administration is looking at. It's been a priority of Republicans for a while. So, those association health plans, and those are tough too. I feel like, I think there's been a lot of concern about, fraud and, worried about kind of individuals buying, through those associations. So it will be interesting to see, if this administration, is able to put something forward, that again, has guardrails, but allows, potentially, large group, insured coverage, to be purchased by kind of, employers, and have it be a way that, helps. Just again, I think we're all interested in, access, right? We want people covered. I think that's the goal. And how do you do that in a way that, like you said, doesn't, hurt kind of the markets that we've created, but at the same time, we're getting people covered that maybe weren't before, right? And, they're priced out kind of in other ways. So, that's another area where I'm certainly watching to see what this administration does for association health plans, to see whether or not that becomes, a viable kind of alternative, for some of these small groups, like you said, this disrupted middle, who we know just can't really afford, that small group coverage in the small group market right now. Does that become a viable option? But again, I think, any proposal that we see, I think, looking at it carefully to make sure, that it kind of has protections in it, for those employers who are in it, because, certainly we have seen some of those who just haven't worked, well in the past. So, but that's the other one issue I would say I'm watching for in the next couple of years.
Thank you. Interesting. So, last question here. Very interested to hear your perspectives. If you could wave a magic wand and make one practical change, so it could be product, policy, process, something else, to improve coverage access for the disrupted middle, what would it be? And Lisa, would love to start with you.
I'll go first. This will probably be my last comment. Unfortunately, I do think it comes down to money. I mean, it was interesting to hear, Dr. Anderson say, like, subsidies, aren't necessarily kind of, I think, the answer in all cases. But I do think if we could have, greater eligibility and subsidies, for kind of a broader, group of employers, individuals, that certainly seems, that has been what has worked, right? Like we have seen the greatest movement and, numbers of people covered when, we're able to kind of, subsidize those costs. Now, are the costs too high? Like, is there a way to bring them down through some of these other programs like reinsurance, some of those, state-run programs, through the federal government? But I do think, trying to figure out ways where we can maybe, move the needle a little bit. I think, there have certainly been policy, options out there about changing the age for Medicare. How do we kind of make this group smaller, covering more people, through some sort of kind of government subsidy or government program. But I think we do need to find solutions, and appreciate you all having this discussion to really think about ways to do that.
Thank you, Lisa. Mike, what about you? What do you think? What would you wish for?
Yeah, it's a tough one, Burcu, but I think I'd like to see stronger financial incentives through the carriers to increase consumer engagement, which, and this is totally theoretical at this point, would offset future healthcare costs. Less catastrophic events, less high claims, and just overall greater quality of life and longevity within people in the United States. And I think that would go a long way. It's a big ask, but it would go a long way in helping to reduce and manage healthcare costs in the future.
Thank you. And Dr. Anderson.
Thank you very much for giving me the last word, which is scary. I'm going to go a little bit off the walls and bonkers because I'm an academic, so I have that liberty. I would really want a substantial reconceptualization of product design. No, first, get away from a 1-year contract, get to 2, 3, 4-year contracts. No, where it might be actuarially equivalent, and we can definitely do something to make cost sharing balance out over time. So that'd be the first thing. And this aligns with what Michael's saying. Like, let's start thinking about longer term investments, because right now, insurers, prevention doesn't make sense on a 1-year contract for anything more complicated than a flu shot. Over 2, 3, 4 years, that's a different story. Secondly, we also have to reconceptualize and be very explicit about that reconceptualization of what is good enough. My friend Joey Mattingly in the New England Journal of Medicine wrote a piece a couple months ago that observed that there was 8 different molecules approved for Hep C. Only 2 or 3 of them are currently on the market at the moment. Which, could we have an insurance product that buys the rights to one of those discontinued molecules, which is still 85% effective, make it effectively a generic or an authorized generic, and sell it for $100 a cure, and then use the high-cost drugs that are still top-line treatment as, the try and fail. So as we reconceptualize what the product is, I think it can be much more efficient, and this gets to the entire discussion about price. Subsidies are needed in the short run, but the more efficient we can make our system, the more effective our subsidies are, which means more people get covered and more people are happy.
Yeah, more resilient market. I just want to say a huge thank you to our panelists and to all of you for joining today. We know, and hopefully you hear from this conversation, the disrupted middle is not a monolith. It includes small businesses trying to do right by their employees, middle-income individuals who do not qualify for subsidies, those who are stuck trying to navigate options that may not really fit their needs. What unites this group is that they're falling through the cracks of a really complex and often unforgiving system. So today's discussion hopefully reminded us that we need smart and bold policy, innovative plan design, and conversations like this one to ensure that affordability, access, don't leave the disrupted middle behind. So we're excited to keep the momentum going, continue to work together. Thank you all so much for joining us, and we hope you have a great day.
Thanks again, Burcu.
Thank you.
Thank you very much.